Good evening, everyone. My name is BJ Arun. I'm the president of TIE Silicon Valley. It's our privilege to host you this evening for a wonderful talk coming up. Just a couple of quick keeping items here. We have our TICON series that we have now actually announced is going to be virtual. So it's actually quite apparent that this year it's going to be hard to have thousands of people come together under one roof. So for the first time in our 27-year history, we have decided to go virtual, but we are actually working really hard to make it as close to the real thing as possible. And the good news is all of our grand keynote speakers, they continue to be committed. And so you will hear from our grand keynote speakers. The other important thing is that we realize we can't have like day-long sessions virtual. It's going to be really hard to be sitting in front of a screen for 8-10 hours at a stretch. So we've broken it up into what we're calling a road to TICON. So we're going to have like one event in June, one in July, and then culminating in one in September. And so the dates are already on our website. And we also have actually announced some of the grand keynotes already. So the June 24th one is going to have legendary VC and co-founder of Sun Microsystems, Vinod Khosla. The July one is going to have the CEO of Niti Aayog, which is Amitabh Kant. He was the IAS officer behind the Incredible India campaign, etc. And pretty much, the Niti Aayog is now what used to be the Planning Commission. So one of the most powerful and successful officers in India, in the Prime Minister's office, etc. And then, of course, our September keynote is Indra Nui. She needs no introduction. So just wanted to quickly update you on what we are doing as far as TICON is concerned. We also have a special pricing at the moment. So what we have done is that just for the cost of our annual membership, which is $150, you can attend all 3 of these TICON series events, as well as all of our virtual events. So all of these events, like the one this evening, etc., they're all going to be included at this one flat $150 annual membership. So do take advantage of that. It actually does go a long way in taking care of our overheads, getting our staff paid and rents paid, etc. So would appreciate if you could do that. At this point, I would like to introduce the moderator for the evening, Venktesh Shukla. Venk is the founder and general partner of a seed stage VC fund called Monta Vista Capital. He has previously been president of TIE Silicon Valley, as well as chair of TIE Global. Prior to starting his own fund, Venk was a senior exec in a number of Silicon Valley companies, both big and small. So with that, I'd like to hand it over to Venk. Take it up from, thanks, Venk.
Thanks, BJ. And thanks, Ty, for organizing such excellent series of conversations. Folks, it's my honor and privilege to introduce today's speaker, Suja Chandrasekaran. I first met her about 5 years ago when she was Chief Digital and Technology Officer at Walmart. Most of the CIOs I used to meet at that time had become CIOs because they were successful in managing the rollout of SAP in their companies 10 years ago. And so we're very good at managing resources, priorities, interaction with executives. But in general, they were not very savvy with cutting edge technology. And that's what surprised me about Suja. She was able to engage, challenge, and interact with deep technology experts from the startups that we introduced her to. And so she continues to be as current in technology as she was earlier. After Walmart, she became the Global Chief Information and Digital Officer of Kimberly-Clark, another consumer retail giant. And now she is the Chief Digital and Information Officer of CommonSpirit Health, one of the largest hospital chains in the US that operates 700 hospitals and healthcare centers in the United States. She also is on the board of 2 or 3 public companies, including one that I remember is American Eagle Outfitters. So with that, welcome, Suja.
Thank you, Venk. Happy to be here.
Great. So, folks, here's how we'll do this. I'll start off by asking a few questions to Suja, and then we'll open it up. So if you have any questions, please send it on the bottom. There is a Q&A bar. Just submit your questions on that. And if you are available, will not only ask the question, but if you are available, we'll ask you to ask that question directly to Suja. If you can, if at that point you can unmute yourself and ask the question. So let's get started. So Suja, again, you've been in different industries before you joined this hospital chain. What's different about technology adoption in this industry compared to others that you know?
So Venk, we are a health provisioning ministry, health provisioning company, and hospitals are one of our channels, right? So we have clinics, care provisioning clinics, we have health at home, senior living, and yes, acute care facilities are one of our areas of focus. Technology at the lowest level, there are some elements of commonality. I would say there is your basic connectivity, there is people experiences, patients, physician experiences. So there's an element of commonality. But I would say the industry in general has, because of pretty heavy regulation and because of other reasons, I would consider this industry a bit behind in comparison to some of the other industries. You would consider going on a cloud as a basic capability. It's not such a novelty anymore. It used to be a novelty 10 years back. But this industry, we are just beginning that journey of getting into the cloud as an example. The data protection, the protected health information, HIPAA regulations, and other regulations means that we have to be very cautious and careful in what we do with technology and data. And but yet it's an industry that is so much data driven. Physicians and clinicians are very evidence based. And you walk into an acute facility or a clinical facility, it is a corpus of data. There are different machines, the biomedical equipment and other scanning and other machinery. So data is everywhere, except that when it comes to that mashup, that synthesis across the board of all this information and the application of technologies, as well as the patient centricity, the industry is a bit behind.
Okay. So you talked about data. We'll have another discussion about data. I mean, I think this is industry also unique in the sense that your most important, most valuable data, which is patient data, is captured, you see, in things like Epic and all these other ones, which are very, which are not open at all and very, very closed. So I don't know how it's fun. Well, let's talk about data right now. What the heck? So, digitally native enterprises like Google and Facebook and Amazon, they constantly use data not only to improve their business process, but to think of new business models, as well as to continue to improve their back office. How relevant is the same thing? First of all, hospitals are not the cutting edge of technology adoption, as you mentioned, for a variety of reasons. And then on top of that, you don't even control the most critical component of that data, which is the user data, which is locked up in Epic. How does that work?
There's lots of different moving parts here. So in general, I would say the industry is behind, but that is certainly the genesis of that transformative applications of technology and data. So that direction is certainly happening. Whichever is the EHR platforms we use, we do have the ability to pull the data out. So it's not the locked up is a word. It is definitely it's an idiomatic description of what's happening. There's a lot of data that is in unstructured formats. Physicians are typing in the data, which is a lot of script. There's a lot of structured information, your biomedical information, your vitals. Those are all structured pieces of information, but on top of it, there is a lot of intelligence, context that the physician or the clinician, whoever is checking you, rooming you, is typing that information as well. So across all of this, we do get a fair amount of data. A lot of decision-making is based on those numbers. There is certainly a direction towards applying artificial intelligence and moving in those directions. So I'll give you some use cases. Sepsis is a major issue, right? You're a patient or somebody is a patient, they come to our acute facilities and there is a possibility they could develop sepsis. And preventing sepsis is one of our priorities. based on various signals, we have a data algorithm that will predict if a particular patient that is checked in, that is admitted into a acute facility, has the potential to develop sepsis. And we are about 85-90% accurate in the sepsis forecast. Likewise, the days of stay is a major metric. So we have predictive algorithms that predict days of stay. There is also a general trend towards addressing physician fatigue. Physicians are constantly applying this data or this information, the context, talking to you, and your behavioral elements, various symptoms, and they're making decisions. So a physician's life has plenty of decisions along the way. So this decision fatigue and helping to influence or inform them further based on various confluence of various data components and giving them insights is an element. And being able to present that at the table side, at the bedside, so that they're able to assess, almost think of in retail, there is the concept of next best action, and think of a similar one, but you are able to then provide that information to the physician. We also apply algorithms to our other functions. We run a supply chain. Personal protective equipment was a major topic, right, in the height of COVID. Right. So PPE and predicting PPE usage. So those are also algorithms. Employee-related algorithms. So we have made a foray into many of these things. Certainly, the journey continues, taking a lot of this unstructured information that is in the form of images, ultrasounds, MRIs, X-rays. So there is a lot of these electronic images, and studying those, machine learning through those images, and being able to develop algorithms to read them or inform the pathologist, the radiologist, based on what is going on. So that's also a trend that is happening. I don't believe it's consistently used in every place, every location, every disease type, every form factor across every facility, not just in our company, but also in across the industry. But certainly there is a trend moving in that direction.
Okay. Now, you said all this, you talked about artificial intelligence. Is that homegrown, or do you rely on third-party solutions for those things?
Combination. Some we build, some we partner. There is algorithms need a ton of data, right? So the beauty of the algorithms and the precision of the models gets richer, more the data is. The data is quite fragmented. Even as a patient, the stickiness of a patient and the loyalty of a patient to a single physician or a facility is very limited. Patients typically go across facilities, across physicians, so your data is locked up in different places, and there isn't a single mashup. Like there isn't an equivalent of a Facebook or a Google that's mashing up all this data. So there is some limitation. Certainly the industry is moving towards how do we get a collection of this data as much of it as possible, so the algorithms get sharper, smarter. So we do both. We have in-house data scientists that are building AI algorithms. We also partner with other third parties such as startups, and the industry does it in many ways as well. So big tech, Google, Amazon also partner with various health systems as they build these algorithms on behalf of other acute systems as well.
You know, talking about access to data, let me ask, there's a question that came around which is relevant to this. Prakash Narayan, can you ask your question to Suja? Please unmute yourself.
Yep. Okay, this is Prakash. Hi, Suja. So my question is, how far are we from the users owning their data in an open EHR record, right? So this way, in fact, the problem that you just mentioned about information from multiple providers, they can be persisted in one location.
So that's the recent ruling, right? So that ruling, the CARES Act has been in progress on various tiers of that kind of data interoperability between systems, data interoperability for various purposes. So that's a major portion. As a part of that, in the last several weeks, months, very recently, I think in the early days of COVID, coincidentally, also came a major regulatory expectation that both the health systems as well as the tech providers have to open up and make that data available to the consumers. So that direction is going. I think the deadline for that is, I would say, a year to 18 months away. We're working towards that. Now, what will happen after that, once the data becomes available, and how would a consumer put that to use? Would that data become then, will it be made available to startups or whoever wants to do something with that data based on some kind of an acknowledgement and agreement from the patient? So those are all, that's a space that's waiting for disruption, and the regulation takes it in the right direction. The regulation certainly is a step in the right direction towards that kind of an exploration. There were pros and cons in the industry and a heavy debate and dialogue around, will it be done appropriately? Will the patient ultimately benefit from it? Or will it be just some technology company or a data company that would benefit from it? So there were a lot of interesting pros and cons, but I think we as CommonSpirit, we leaned heavily towards that open availability of data, and that will ultimately benefit the patient and therefore the community. There's also components of price transparency that was part of that the latest regulation. So that regulation is going in the right direction, and I think startups have a good opportunity to shape where that is heading, to put the data to good use on patient benefit and making patient a single portal or a single pane of glass of patient information. So I like all of you, I go to different places, my husband, my children. There is no one place where everything is at. I have such a stickiness with my Bank of America app. I don't have any stickiness with any health app because there is no data. There is not a good app nor enough data. So those are all possibilities of a future business model, which are patient-centric, and the patient consumes the data in a fairly longitudinal stitching together of data.
Okay, the whole bunch of other questions, but let's ask the macro level question first. What's your definition of digital transformation for the healthcare industry? And a related question is, in your view, what does the promised land of a digitally transformed hospital look like? And how will an average consumer know the difference?
So, Venk, for us, digital is about human centricity. It's about patient centricity. It's about the human persona could mean a patient, consumer, physician, clinician of any kind, or employee. So in digital means creating value in a human-centric way that enables people and augment what we do through technology and algorithms. And it's almost a way of survival in a digital world and survival in a post-COVID world. So it's a broad-based definition. For us, it includes different products that we deploy and that transform some of the fundamentals of the way in which we deliver care on the continuum of care, all the way from some of the basics from other industries, such as being able to find a physician and being able to assess and compare physician scores and ratings and reviews, through to be able to make schedules online, through to finding care anywhere. Care anywhere is a major topic in the light of COVID. The televisits, telemedicine has become a major topic. And we can go a bit deeper onto that topic. But so is personalized medicine, precision medicine, digital therapeutics, and digital operations focused inside our facilities, inside our healthcare itself in terms of improving operations. And so it's a broad spectrum of products, platforms, and capabilities that are focused around better human experiences that ultimately drive value for our communities and for our company. And so it's not just efficiency based, it's not just one topic based, it's a broad spectrum of topics. And we are going across many of those, even all the way from creating content. WebMD was one of the biggest content portals for a long time. Mayo Clinic has a good portal. So you start Googling your symptoms and you hit on these websites, and it's still not so precise, right? So I search, and sometimes I keep searching. I have to search for an hour before I find 2 questions I can take with me to a physician. So content is another major component. So digital is across the board, and we are making quite a bit of a progress across that. And just in light of COVID, we went from our total visits, we were about 2% of our total visits was virtual through televisits, virtual visits. Now we are north of 50% of our total visits are virtual visits. Likewise, inside the acute facilities, we have a fair amount of virtual care, virtual sitters. Sitters are companions that are part of monitoring a patient that needs monitoring, and typically it's a 1-on-1 ratio, but we make the virtual, so now we can get to a 1:6 ratio. And in addition, the patient gets a better care. And likewise, virtual rounding, doctors are walking around the wards, the ICU wards, the general wards, and think of all of that as going virtual. So you're not walking anymore, you're doing it in a COVID context, in a minimal availability of PPE, that was extremely important. But now, even as COVID is beginning to subside, physicians are preferring those kinds of models. And likewise, the virtual ICU, and ICU is a pretty intense location, as the name indicates. Typically, there is one nurse. It's a dyadic monitoring. So a nurse is in the ICU room 24/7. But even those we are working, and there are models to go and take those virtual. And of course, application of AI to the previous conversation we had. So digital is a broad topic. Ultimately, it has to be about human experiences, and it has to create value. It's not just throw out technology.
Okay. Well, in this context, let me bring Mimanshu Patel. Mimanshu, are you ready with your question? Go ahead, please.
Yeah. Hi, Suja. I was wondering, how does one justify the cost for creating a unified unstructured data management kind of solution when most companies are, as of now, running towards lowering their OPEX and CAPEX kind of spends. And on top of that, we have, issues and reasons how to mitigate, GDPR, HIPAA kind of regulation risk when we are trying to merge these data sources that you mentioned are in silos lying with different departments.
Mimanshu, thank you. So the value of the data is the use case, right? So data in itself is relevant in a transactional model, but in the context of bringing the data together, the value really is in the analytics or the artificial intelligence or whatever is the algorithm, and then the use case and the ultimate result that comes out of the use case. So the justification comes from that outcome. And this is also not just from the healthcare industry, but even in other worlds, just bringing the data together is very difficult to justify. But bringing data together for the purpose of bringing contextual transparency, near real-time transparency, being able to build learning models out of those and drive algorithms out of those. So those are how we justify building the data platforms, the core data platforms. Did you have a second part to the question? I'm sorry, Mimanshu, I may have missed the second part of your question. Yes, so compliance. Yes, compliance does get complicated, but we are GDPR. HIPAA takes even one level further, right? GDPR and CCPA, these are traditionally, they come from the consumer world where mass volumes of data, behavioral data, and purchase data, search data, et cetera, came into picture. And so these provided a vehicle for any consumer to opt in, opt out, right to be forgotten. So those came into being. In a way, PHI is a lot more stringent to begin with than some of the regulations, right? GDPR and CCPA. PHI cannot be sold. So just as basic as that, right? Where there's a lot of monetization, a lot of business models on data monetization that happens in other industries, PHI cannot be directly sold. And the right to consent and the right to be forgotten on, all of those are very much part of this equation. And that's where do you get anonymized? Where do you, the aggregation, so the way one of the elements is there's a lot of de-identification that happens, and then there is aggregation. So the moment you aggregate and you cannot decompose into a subcomponent level, into a specific patient level, that is one way of working around. And then unstructured data is also, people think unstructured data is not PHI, but it's very much PHI. Even if you remove the patient information, sometimes in an X-ray, there's a physician writes your name and put some diagnosis. So it's interesting to be very, very careful to make sure regulatory requirements are taken care of, but there are ways. And we didn't have a policy. So one of the things we are doing right now is a policy of what do we do for data sharing. It's not just lock up, completely lock up, don't give data to anybody. It's also not a free-for-all, just give it to anybody who shows up at our doorsteps. So what exactly is our governance process, our policies? What are the legal angles? So it's not just a PHI and a HIPAA and a regulatory angle, but there is also legal angles to it. So we are codifying that and putting in structures, internal governance as well as external governance on what it means to be able to share this data and put it to good use. And not get in, and you've seen some headlines on one of the other systems that showed up in the headlines for the data partnership that they ended up having with a big tech company. Even though I do think that the intention was pretty benign and the intention was pretty safe, you don't want to show up in the headline. So we are very careful in the way we look at it, and we are very methodical, we are compliant, we are legally bound, as well as we govern it internally as well as externally.
There's a related question to that, which says that do you think that this form of analysis of healthcare data is restricted to a particular medical area like chronic conditions, infectious diseases, or is it more universal?
Oh, it's across the board, right? Service lines, it's across the board, and it's almost service line by service line. So let's just peel the onion and talk about the data sets. So the health record is one data set, right? So the electronic medical record, whatever is in the health record is one data set, but that's not the only data set. It's your traditional consumer data set, typically what a general platform, Google or Facebook would collect. But then also your genomics is another crucial data set. And then your phenotypical data set, your behavioral data set. So the value of personalized medicine comes across multiple data sets. And the solutions and the offerings of the solutions vary, and they are across the board in multiple service lines and multiple disease lines. Some are more advanced than the others. Some disease types are more than the others. Right now, COVID is a major focus around data, right? And we have seen the use of data and the models, sort of the predictive models, the epidemiology researches that are happening, the data, the age groups, the race-based assessment on the infection as well as the fatalities, the comorbidity correlations. So there's a fair amount of analysis just happening in COVID. That's just one example of this massive epidemic that we're all experiencing, but it is no different across the different service lines. And startups have done some pretty good work, right? Flatiron was one good example. We were a partner for Flatiron. At some point, built an electronic health record system focused on oncology. And then that they had and then they took the data, built models out of the data, and then they had an exit with Roche, a fairly large exit with Roche. So that was one example focused on oncology, but there are numerous other disease lines, service lines, care groups and care families that are going after data-driven, data-centric, personalized medicine and research.
Okay, let's go to Shanti. Is Shanti on the call? Shanti, please go ahead.
Yeah, can you hear me?
Yeah.
Okay, great. So my question was around more on the back-end data side. So the healthcare industry, we've been working with a couple of companies in this area. They seem to be kind of reluctant to store the data in the cloud, and we've been doing a lot of cloud education. The cloud vendors have done so much work trying to ensure that privacy, security, and all of the regulations are guard the actual data. And even when if you're not storing the PHI data, there just seems to be this fear of the cloud. And I was wondering, in your opinion, if there were other factors that were going into this that we are perhaps missing?
Yeah, absolutely. There's definitely HIPAA, respecting HIPAA and the regulations and the isolation in the cloud, making sure that the regulatory tests are passed. So those are absolutely a basic expectation. The clouds are all getting there. So there is no major cloud provider today that cannot do that. So which means that you can pretty much go on any of the big three, and even the long tail that's after that, they should be able to do that. But there is definitely the fear of the unknown, the concerns of what are we missing by means of putting here, the general perceptions. So there is generally the change management, mental change management effect of going from on-prem to the cloud. That is definitely a factor as well. Sometimes it's also price point, right? If somebody internally in some of our data centers, we can do a lot of efficiency, virtualization, automation just in our own private clouds. We can bring in a lot of efficiency that our price point, sometimes the unit price point is much better than sometimes what you get on the cloud. And you don't go on the cloud just because of that, but that could also be a factor in the consideration. But it's more than just HIPAA. Those days are gone. That would have been the case, I would say, 10 years back. And that's why the industry sort of sat it out. I will give you an example. One of the large EHR vendors just announced last year that they were going to go on the Amazon cloud, right? So it's a good thing. It's a good news. It's a bit late than the other industries, but it's a good news that they're going on Amazon cloud. And so that these kinds of journeys, you will start seeing them more and more. There is also a proliferation of a lot of SaaS products that are coming up, and SaaS by virtue is in the cloud. And each of the SaaS product is doing a little bit of breadcrumbing. They're taking a little bit of data that's also going to the cloud. So it's a tricky dance. I'm thinking about it and thinking through for ourselves. I am less worried if we have our own public cloud that we get on and that's HIPAA certified and compliant. I'm more worried about this breadcrumbing of the data that's ending up in all these SaaS platforms that we work with. And suddenly, before you know, there's a ton of our data sitting in so many different platforms. I'm more worried about that. I'm less worried about building our own data platforms in a public cloud.
Okay. Let's get Sachin to ask his question.
Hi, Suja. Can you hear me?
Yeah.
Yeah. So as we know, in this country, the cost of delivering care is high. So from your perspective, like many other industries are able to transform themselves digitally and bring down the cost, pass it on to the consumer. But from your perspective, how do you measure the ROI for all your digital transformation programs? And do you see that the cost coming down the pipe and will be pass it on to the consumer in some future time frame?
Yeah, see, it's a great question, right? Because it's the industry is so complicated. I go to in any other place. I go to a restaurant, I make a payment. I have my meal, I make a payment. I go to Walmart, I buy a product, I make a payment. Whereas you come to our facility for care, and I take your payer information or whatever the way you're insured. I have no guarantee that I'm going to get paid for even for my cost or anything that I have priced that service to be. So it's a fragmented industry. There is a nice chart, you can Google it. It's for every dollar spent. So this is a $3.5 trillion industry just in the United States. And for every dollar spent, there is X percentage that goes to big pharma, X percentage to the supply chain side of the pharma, the Cardinals and the McKessons of the world, X percentage to the retail pharmacy, and you keep going down, right? So and then the provider, it's not a big number. The provider margins are not that big, right? So and we're all at the mercy of, ultimately the revenue is from the payer. For us, the payer has to provide us the revenue. Sometimes we do take credit cards as well. That is a direct to consumer and you pay a credit card for your service, but that's far and few between in the big scheme of things. So it's us, especially as a faith-based nonprofit, we are always working towards that community angle. And this is public information. So we are about a 31 billion industry company. Out of the 31 billion, think about this number, 6 billion is contributed to the community back because somebody came in and they didn't have insurance, or somebody came in and they couldn't afford a certain surgery or a service line. So 6 billion of 431 is contributed back into the community in some way, shape, or form. And then on top of that, we also work towards how do we optimize and improve efficiency and how do we provide better care. And that's an angle all the time. Think of the other disruption and massive transformation that's happening in the industry, which is the pay-per-use model versus the value-based model. Population health, definitely, which is a mandate, which is a direction that the government is moving all of us towards, is definitely that you take lives under you on a capitation, and it's a risk-based model, and you're paid based on the risk, and you're not paid for the visit. That means you're now really taking care. I mean, do you have your flu shot? Have you had this X considered? Have you watched this? And so you're much more holistically engaged and part and parcel. Have you done your full physical for the year? So we are more part of your life and your broader health spectrum. So you don't have to make the visit. It's as opposed to you do have the flu and you have to show up in the emergency room. So we prevent that by means of being part of your life holistically. So that's a model. We have about 2 to 3 million lives under the value-based model. We are one of the leaders in that angle as well. So that's also an angle of optimizing cost of healthcare overall, while at the same time improving the experience for the patient.
So before we go on to other questions, there's a question on gut biome and in the healthcare system. And Suja, I noticed that your child prodigy daughter is also on the call, and I understand she is a Forbes 30 under 30 in healthcare space. Let's hear from Sona on her area of expertise. This is her area of expertise. So Sona, please share what is exciting in your area of healthcare. What's going on there?
Hey guys, can you hear me okay?
Yeah.
Okay. So I'm a co-founder of a company called Oshi Health, which is really sort of reimagining care for patients with gastroenterological diseases and digestive health diseases. We're essentially a full stack virtual care provider, where we have a team of providers aboard our platform, including a gastroenterologist, mid-level practitioners like a nurse practitioner, dietitians and a psychologist, really delivering holistic end-to-end care for patients in a very sort of convenient virtual manner. We really sort of identified a lot of pain points in this particular population. They're largely underserved. They're actually really quite high prevalence. So 15% of people have irritable bowel syndrome and 20% of people have GERD. But they are often really sort of an often neglected population. And so we've built this end-to-end platform as a way to really sort of move the needle in GI care.
Okay, that's interesting. Well, so why are they underserved?
So really, like if we take a particular population, so patients with irritable bowel syndrome, these patients, they have a disease that's it's called a functional disease. So in gastroenterology, there's two kinds of diseases. There's structural and there's functional. When you have a structural disease, you can point to like an anatomical location in your body that's causing that disease. You can say, okay, you're having your symptoms because your gut is inflamed, and there's clearly, when we do a colonoscopy, we can see that. The thing about irritable bowel syndrome is that it's functional, which means that there is no direct place anatomically that we can say that those symptoms are being caused. So a lot of the times these patients are dismissed as having psychosomatic symptoms, and clinicians don't really take them seriously. So it takes an average of 5.5 years for an IBS patient to reach diagnosis. And in that time frame, they're sort of going from clinician to clinician, really not getting the full attention and care that they deserve, having sort of a lot of difficulties being taken seriously, until finally, after years and years of sort of suffering and looking for relief, they might sort of end up in the office of a gastroenterologist, where they're finally given a diagnosis of IBS. So there's a lot of challenges there. I think that healthcare historically is very fragmented, as has been discussed on so far. We really want to sort of tie together the pieces of healthcare for our patient base. So a lot of GI clinics are, they're based on a fee-for-service kind of model. And when provider practices are sort of when clinicians are incentivized based on a fee-for-service model, they tend to sort of focus their efforts, whether consciously or unconsciously, on driving up procedural volume. And so a lot of the times you'll see these GI clinics they're sometimes nicknamed scope shacks, because they often sort of are over prescribing things like colonoscopies and endoscopies when they're not clinically necessary, and really not focusing their attention or care towards the lower complex patients that don't require those kinds of procedural those kinds of procedures like IBS patients. So that's, we're really trying to focus on bringing care to a kind of drastically sort of underserved and dismissed patient population.
Great. Yeah, thanks for that insight.
Yeah, sure.
All right, let's go on to the other questions there. Boy, the questions have lined up a lot. So let's go to Shal. Shal, are you ready with your question?
Yes, I am. Can you hear me?
Yeah.
Great. As many in healthcare industry have enabled access to medical transportation and or telehealth to address social determinants, has CommonSpirit organization initiated technology solution in this area? Is it relevant only for a specific patient population? And in this current COVID-19 situation, how do you take that into account to address social determinant solutions?
Social determinants is a major topic for us. I haven't seen a direct application of telehealth towards social determinants, but being able to collect data and look at social determinants is something that we are exploring. I don't believe we have, it's certainly at the point of care that is a question that is asked, but in a mass manner, being able to assess population health and being able to address that is a work in progress. Telehealth definitely addresses rural areas and improves access. In the context of COVID, telehealth was such a boon because nobody was traveling, nobody wanted to go out, nobody wanted to go to a clinic and get infected. And the lack of PPE means we also need to protect our physicians. So televisits in general have been a boon in light of the situation, but more to come on the space of social determinants.
Anything specific you would want to add into medical transportation as part of the access to the care?
We do have a deal with Lyft for discharging patient discharge. We are definitely piloting drones for delivery. It is sometimes within the campus for delivery as well as in rural locations. This is all early stage pilots, but those are the couple of advanced thought processes I can share at this point.
Okay, let's go on to the next one. Deepti Desai, are you ready?
Hi, yeah, sure.
Go ahead,
I asked a couple of questions, so I don't know which one. Is it the one about the federated database, or is it the one about
yes. Yeah, let's go with that.
Yeah. So, Suja, I know that in healthcare, every healthcare hospital system has its own database of patient data, etc. And yet, for some of these rare diseases, you need a lot of data in order to come up to some kind of a modeling or solution. So, how about data between different systems? Is it possible to bring it together in a federated way so it still stays anonymous, it still stays their data, but yet it gets shared in order to bring about greater insights? Do you see that happening?
Oh, yeah, I think that's a brilliant idea. I think it's a brilliant idea. Either you train a model and then you continue to train it in other locations. I think that's a brilliant idea. Somebody needs to explore that, Deepti. I'm not personally aware who is doing that, but maybe you do. But it's a brilliant idea because that is thinking like that would be necessary. We are right now exploring a partnership in which we will have people within our firewalls who are building models to train it, and then they're going to do the same thing in different locations. And I'm sure we will have to figure out something like this where we're able to export the model, because the model itself doesn't have PHI data, but how do we federate then the mashup of the outcomes of across those models?
Okay, let's go on to Manish.
Hi, can you hear me?
Yeah.
Hi, Suja. I'm actually I'm a CIO at one of the India's largest hospital groups out there back in India. Question for you is that do you see the US hospitals leveraging any offshore tech talent or any offshore clinical data without crossing any of those US regulation boundaries? So that's one question. The other question was integration of medical devices has been a challenge all the time with Siemens, Philips, etc., all closed down. And we have seen the challenges in India as well. Any examples you can share where you have actually integrated medical devices?
I'll take the second question first. Pretty much, we are integrating every biomedical equipment we've got, irrespective of the manufacturer, irrespective of the kind of data it streams, integrating biomedical equipment into our EHRs. Sometimes it's directly integrated to telemetry, or it is integrated to EHR, and then we integrate the EHR to the telemetry consoles. But integrating them is absolutely part of any of our implementations as we address technologies in our various facilities. I think the cross-border integration, cross-border research, sharing of information, sharing of data, I think that has to be explored further. It's a bit of a tight industry, right? So one of the large EHR platforms, and it's a commonly known piece of information, so Epic does not allow their allows support for Epic to be done outside of the US soil, or there is some kind of a regulation such as that. And Epic, they're great partners for us, but it's to that extent, right? So leave alone being able to share data and being able to research data. So the offshoring of health systems outside of the US is fairly limited. It's there, but it is limited. I do have some partners and some capabilities that are offshored in India and the Philippines, but it's very limited. But it's something that must be explored. I do hope and trust that COVID opens up those barriers and it forces us to work together as humanity, because I think we can do a lot better together.
Great. Let's go to Daniel Babanzad.
Hello.
Yeah, Daniel, you're online.
Great. Hi, Suja. My company Botsy is working with hospitals through autonomous mobile robotics to deliver goods autonomously, resulting in reduced injuries and improved operational efficiencies. I'm curious if you see robotics as an integral component of digital transformation.
Totally. Absolutely. Surgical robot, right? Surgical robots are coming in everywhere. It's not a novelty anymore. But the robots that are part of that mobility, internal mobility, those are also most likely, those will happen. It's a productivity, it's a price point, unit economics, as well as productivity, value creation conversation.
Great.
All right. Nagesh? Is Nagesh ready?
Yes, I am.
Okay.
So before I ask the question, I want to comment on the thing that you mentioned about training models in multiple places. So at first, we can actually solve that as a small data mini models problem. And then you can actually ensemble those models and have some kind of voting to be able to actually get something that is actually pervasive across the entire hospital system. That way you can actually come up with something that is both global and local, and optimize the results. So that's essentially for the machine learning part of the discussion. I'm Nagesh. I work with a company that is actually creating a platform that curates data from all the healthcare sources, including EMR systems, and creates a doctor-centric and a patient-centric views with overlays for how hospitalist works with care managers, utilization managers, and specialists and the like to do things like medical necessity evaluations, charge capture, EDI, RVU calculations, and things like that. So my question is more from not the clinical side, but from an administrative side. What do you think are the biggest cost sinks that you want to go after?
It's a big that's a big topic. Sona, do you want to take that one? You were talking about that earlier today. Sona, are you still there?
Yeah, I'm here.
Do you want to take the question? Did you listen to the question?
So the question is around the opportunity for
the biggest cost in a health provisioning and how you can take advantage. Now, let me take that. Okay. So, Nagesh, your first point is in the ensemble models. I think that's a brilliant idea. The catch would be that no one system has the full view of a patient. Mm-hmm. And therefore that full longitudinal view of any single patient may or may not be with a single system. But I do think it's something to be pursued. The ensemble models would be the way. Cost it's a service industry. So there's different places where if I look at our P&L, our balance sheet, we are very, very heavy, asset heavy industry. Very heavy balance sheet, lots of assets, hospitals, buildings, biomedical equipment, IT software. So all of these are capital intensive. So that anything that can be done to reduce or minimize that, and the unbundling of the healthcare, unbundling of the hospital could be one of the elements. The second is payroll, right? People. So automation of anything, clinical automation, virtual inside the acute is a major topic, right? That's why the sitter use case that I gave you, 1:6. One person in a room, virtual companion with one patient versus one person virtual can be a companion and a sitter to 6 people. And it's also an opportunity because we don't have that much capacity in each of the hospitals. We can even add more virtually. So that's also a revenue stream. So I would say really the asset heavy industry, the unbundling virtual, focusing on the care continuum. So care is not just a hospital thing. Definitely clinics are a big part of it, but the health at home, the senior living, and the community care. So a lot more location on the unbundling of the services and the procedures is another angle.
Okay, let's go to Brian Leggett.
Yeah, hi, Suja. I'm wondering, how do you view your role, the role of RPA in your workforce automation and digital transformation strategies post-COVID? Is that an area of technology you're looking to invest more heavily and use it perhaps in different ways?
Digital operations in general is a topic, right? So to drive productivity internally, and RPA definitely falls into that space. And I've done RPA pretty heavily in the past. And at some point it starts plateauing in value because you're really just stitching known processes, known steps, and there is a lot of inherent inefficiencies in those RPA steps. And all you're doing is automating those. So a complete redesign, a digital process redesign, a digital rethink of the process models, all of those are part of the equation. And wherever any process automation, RPA or cognitive automation, or any form of automation would be certainly part of that.
Okay, let's go to Sukino. I don't know if I pronounced that right.
Yes, it is Sukino.
Okay.
Yeah, which is in Sanskrit, free of suffering, joy.
Great, go for it.
So, wonderful to meet you, Suja. I've been in telemedicine for more than 15 years. I've been involved in building perhaps 2 of the largest telemedicine networks in the world. NASA has been my springboard. My question to yourself is, what are your thoughts on Mercy Virtual and how it operates? As you know, it's in Springfield, Missouri, and it's a 700-strong hospital without any beds. How are they working? It is kind of part of a technology question and an administrative question in terms of what is your observation so far in terms of optimizing unnecessary emergency visits, readmissions, prescription drugs is one set. How are they mixing their in-person and virtual visits effectively, maintaining data integrity, security, and compliances?
I need to study Mercy some more. I've been in this industry for less than a year, so I've heard about that. I've studied that once, but it's yours is a good reminder that I need to study them some more. But certainly, we are taking our hospitals in that direction of that high productivity, low asset model as much as we can. And there is a lot of interesting situations, right? So we have a massive pilot of a virtual nursing unit, a VNU, and we piloted this 10 years back, and it was a very visionary set of capabilities, but it was so capital intensive. It took a lot of training, but there are a lot more simpler models available. So from my own example, inside the acute facility, do we need integration with EMRs or not? Can it be as simple as just a video conferencing and an audio voice recognition? How could we make that integration with the EMR much more simpler? How can we be a lot more touchless and engaging, and making sure that the provider and the patient can get together much easily? And then providing the continuum across monitoring at home and going virtual with everything, right? So there is a whole path of continuum, and I don't have a direct point of view, and I haven't studied the Mercy model much deeper than that. On the televisit side, I will say on the consultations, the industry still needs to mature. There are a few players, but we are still a long way away from service line by service line, mapping out care family specific. So a visit for a primary care is different from a visit for a mental health or a perioperative, a post-operative visit after surgery. That visit, a televisit, is different from, let's say, an oncology visit, or some visits have a higher propensity for televisits than others, but even those that have a high propensity, the journey of the patient and the journey of the physicians are different. The ability to be able to use virtual or your consumer wearables in the device and being able to use those as substitutes and proxies for the vitals that are typically taken in a hospital environment, those still need to go a long way. So I would say technologies across the board in virtual, and perhaps your business is different, but technologies across the board are more like version 1 technology. Version 1, maybe a version 0.5 technology capability, and they need to go through a lot more maturation to the kind of platforms that I'm used to coming from retail, consumer goods, and digital marketing. So the platform concepts of what is needed are still ripe for disruption. What we have is still pretty basic.
Okay. All right. So, we are, let's see, we can take one more question, and there are a whole bunch of other questions, but I don't want to miss the question that I had in mind to ask. So I exercise my executive privilege and ask you the question that's of benefit to the entrepreneurs. So where do you see opportunities for startups in healthcare? And let's ask that question, then I'll ask the follow-on question.
So I think in the peak, I remember in the peak of the days of where digital marketing was disrupted or retail and commerce was disrupted, the venture capital investment coming into those areas was enormous. And I believe healthcare has a certain amount of investments, which is increasing, but it's still, I do not believe is at the same level as the peak days of retail and marketing and ad tech, martech. So that would be one disruptor, but the startup, I believe this industry is ripe for its disruption, the unbundling, the decomplicating the very fragmented landscape, applying technology and data. So I look at that as it's very difficult for a startup entrepreneur to think about this landscape and see how in the world am I going to make revenue out of this? Because it's pretty complex as to where do you make revenue. There's the direct-to-consumer models is certainly one way to go, but the example for me would be when you look at One Medical and Galileo, these are built entirely based on direct-to-consumer models. They don't, at least initially, they're not bringing in the payer complexity. So focusing on applying technology, thinking about the EHR of the future, still there is no way. My question is, where is the Salesforce of healthcare? Where is the Workday of healthcare? When are they? Who is building it? Who is cooking that in the garage today? Not just that it's on the cloud and it's got a better mobile UX, but it's truly digital native. It is AI infused. It is modern. It's built with consumer centricity. And where is that? That's a huge industry in itself. All this data conversation that we had, that's probably the next $1 trillion is as we crack the code on staying compliant, truly putting the consumer at the center of the world, and still figure that out. That could be a huge industry in itself, and it would have a significant impact on humanity, on how diseases are diagnosed or prevented and predicted. So the opportunities are ripe. The opportunities are ripe in the industry for a startup. Just stay smart on the business models and where you're going to create revenue.
So, and if some entrepreneur has a great idea and they're encouraged by your receptivity to innovation, how do they get hold of you? Or how do they get hold of someone in your organization to pitch their product or technology?
We do have an innovation arm, so that is always one. I'm in the process of setting up a tech garage, so that is another way of coming in. This is always the $100,000 problem, right? So from a startup side is how do you curate which CDO or CIO or CTO to get engaged with, or a head of innovation, so you can get your idea picked up and partnered. And then from our side, it's 1,000 people or 1,000 startups are contacting us. So how do we curate it? So it's a curation match problem. And I don't think I've ever, I don't think I cracked the code on the magic of it. It's almost like, oh my God, should I get back?
Maybe Ty should help you. Maybe Ty should help you on that.
Maybe you should help me, Venk. Yes.
Okay. Maybe we'll curate some 8-10 startups and then present it to you.
That sounds awesome. I think that'll be brilliant.
Okay. Do you have a Twitter account? How do people follow you? Do you write? Do you publish? How do people follow you?
LinkedIn would be great. I generally accept most invites, and then Twitter at Suja Chandra is my handle. LinkedIn, it's not that difficult to find me on LinkedIn.
So Twitter handle is Suja Chandra?
Suja Chandra, that's right. And then I post occasionally. I'm not a big blogger. I've been in companies where we haven't done much, but I do post every once in a while. I'm posting something that's my personal opinions, perspectives. So I do post, but it's not like big articles.
Oh, great, great. Suja, this has been a fascinating conversation. And obviously, with a very, very engaged audience, we still have another 20 questions in the list that we could not get to. But I think this is great. And hopefully, you'll be open maybe next 6 months to a year.
Absolutely.
All
Happy
right.
to, Venk.
Great. On behalf of all the people who registered, thank you very much.
Venk, thank you. Thank you to TIE Silicon Valley. Thank you to all the audience and the great questions. I apologize that I couldn't answer everything. So Venk, maybe you can send me a copy of all the questions and we can try to respond in some way, shape, or form. And thank you to Sona Chandra for her answer on IBD and IBS.
Great. Thank you, guys. Bye. Hey, Nihar? Nihar?
Yes.
Can you, while you are still live, can you get a list of participants?